to be able to sponsor this luncheon symposium, where we'll have an opportunity to really dive into a new tool introduced by Philips called the HeartModel. As we know, the global burden of heart disease continues to grow, and it's important as this burden grows that we have really very strong tools to be able to assess left ventricular function. Not only does the HeartModel address the left ventricular function, but it also looks at the left atrial structure as well. And it's my pleasure today to be on the stage with Dr. Roberto Lang from the University of Chicago and Dr. Simaporn from Chula Hospital. They'll take us through their early experiences in the development of HeartModel. So at this time, I'd like to welcome Dr. Lang.
If you could, okay, great. So, good afternoon. It is my pleasure to share with you our experiences with HeartModel, a piece of software that we have been working now for about maybe 3 years. So, we had previously said today that with the recommendations for chamber quantification, with the new recommendations came for the first time now the proposal that we should evaluate the left ventricle and the right ventricle using a three-dimensional echocardiography. And as you know, in the marketplace, there's a lot of software for the assessment of the left ventricle. There is not so much on the assessment of the right ventricle. We had mentioned today that if you had to think about it, there are two main reasons why 3D echo is more accurate than 2D echo. And the most important one is that you avoid foreshortening, because when you acquire this big volume or pyramid of data, you can sort of search inside it for a non-foreshortened view. And the second one is that we are not dependent upon the geometry of the ventricle. In reality, we look at the endocardial and we can quantify segmental dilatation. When you look at accuracy and variability, I think it's very important to think is that when you try to develop a method, you would like to develop a method that is both precise and accurate, meaning that all of the data that you obtain are really precise compared to a gold standard. Unlike what you would do is a method could be precise and inaccurate, meaning that all of the measurements are sort of similar but are inaccurate. And then, of course, we have methods that are imprecise, that the results can actually, when you average them, give you a normal results, but with a huge standard deviation, or you could have results that will provide you with a wide scatter. I think that as I explained to you the HeartModel, it's important to understand that 3D echo continues to underestimate the volumes compared to cardiac MRI, and the main problem with the error is exactly where we draw our border. And there are those of us who like to draw the border whenever we can in between the compacted and the non-compacted myocardium or the trabeculated. There are some people that like to draw the borders more on the inner side of the trabecula. And that has a lot of implications. And I'll talk to you a little bit more about that. Now, this model has the big advantage that it allows you to not only quantify the left ventricle, but also quantify at this point in time also the left atrial volumes. They're usually calculated at end systole. A calculation of LA volumes is recommended by the ASE, and we all understand that the volumes of the left atrium are actually, they provide information regarding cardiovascular morbidity and mortality in a wide variety of setups. The risk of developing heart failure and the future risks of TIAs and stroke. When you look at the left atrium, here is yet another situation in which, if you look at these graphs here on the left, you're comparing 2D echo versus cardiac MRI, and you can see that there is quite a large underestimation of the volumes, and there is quite some scatter. When you do 3D echo, the limits of agreement and the biases get reduced, and you can see that you become much more accurate. So 3D echo is also more easy to think about because it's usually a cylinder. Now, one of the problems with 3D echo, both for the left atrium and the left ventricle, is truly where do we find the true border? And that is something that I'll talk to you in a little more. The other thing important is that what we are supposed now to do in the echo lab, to do biplane left ventricular and left atrial volumes, is very time consuming. If you take an echo lab, for example, that does 50 echocardiograms in a day, that would take you about 3 hours to do approximately 50 patients. We calculated that for one patient it takes approximately 3 minutes and 30 seconds to do this calculation. So about 3 hours of the day go in making these calculations with 2D echo. Now, when you think about it, I mentioned this in my talk earlier in the morning, is that 3D echo has not been truly clinically incorporated into the routine of daily practice. And there are many limitations as to why this happens. One of the problems is that up to some time ago, we needed to use 2 different transducers to obtain 2 and 3D echo. That has now changed because we have a single transducer that integrates all of this information. You also, in the past, needed to do a reconstruction to obtain a 3D echo. That's not anytime a problem now. But anyway, now the main problem is that you need training, and these calculations are time consuming. So the big solution for this is to develop a program that will be accurate and that would at the time be automatic. So this is a little bit what I am going to be talking about. And this is the HeartModel. The whole idea of this model is to take a chunk of ultrasound and for this program to automatically find the volumes of both the right and left ventricular chamber as well as both atria. So when you create a program like this, you would want it to be accurate. You would like to allow point-of-care assessment, that when you do it, you can analyze it, provides you rapid results with minimal interaction between the user and the software. And of course, you want a program to be reproducible. Now, the creation of an automated heart model is not something that is completely strange, and Philips, as well as other companies, have done it. This has been previously done on CTs, and lately it has also been done in MRI. And I think this is the first effort to try and apply the same principles of automated model-based segmentation on cardiovascular ultrasound. And this is a little bit the idea of this. You would like to be able to automatically identify the end diastolic and end systolic volume, as well as the left atrial volume when the LA volume is the largest, which would be at end systole. And of course, you would like to do the same thing on the right-sided chambers. At this point in time, this model is now ready to be used both for the left ventricle and the left atrium, and a lot of work is happening now to make this work for the right side. Now, in order to create a model, what needs to happen is, initially you need to create a library of 1,000 echo images, approximately. And these echo images were obtained from different sites all over the world, because as we all understand, there are differences in both the size and the shape of the ventricle in different ethnic type of populations. With these 1,000 sort of echoes, you can create a generic model, and then what the model needs to do is needs to adapt itself to the particularities of that same echo in order to obtain a final model. This is a little bit what this program does. It takes initially the heart that you're trying to study, it finds it, and it orients it within this block of ultrasound. It automatically tries to correct for foreshortening, and then in a second stage, it adjusts to the local borders of the heart, and thereby, again, avoids any type of geometric assumptions. By creating this very robust library, it is possible to identify the different types of shapes that the heart have. You can have a dilated, a banana-shaped, a patient that has a sigmoid septum, or a normal-sized algorithm. So these are all the types of shapes that have been sort of accounted for. Because of what I mentioned earlier, that there is this problem of where we draw, or each of us like to draw the border, this program allows you to very rapidly, for the user, to define where you want this border to be. Do you want this inner border to be located at the blood tissue interface, or do you want it to be slightly outside between the compacted and non-compacted myocardium? So this is something that is very easily configurable, as I'll show to you in a minute. The other possibility is that this program, once it works, and I'll show you in a minute, will present the apical 4, apical 2, and apical 3 views in both end diastole and end systole with the borders that you can then globally adjust, as I showed to you before. And then if you still continues not to be happy, you can do some regional editing. In my opinion, after using this program many times, you need to do this global and regional editing in about 20 to 30% of the patients. And this is an example of the 22 seconds it takes to analyze a program. You see, you tell the computer to analyze the heart model, and then it takes around 21 seconds for the computer to initially identify the endocardial borders in the apical views, in end diastole, and in end systole. And I'll show you now as it does. When you do this, you see how long 20 seconds can be, but this is the end diastolic and end systolic borders shown. You can then, if you wanted to, you can change these borders globally and make them larger or smaller, or you can go and regionally find the borders. You can see that these borders, now the computer has identified the endocardial and end systolic borders of the 4 chambers of the heart and provides you with data. I'm going to show you some examples where this model is still not working. This is a typical patient with a right ventricular dilatation. When you try this, the model thinks that the left ventricle, that the right dilated ventricle is the left ventricle, and makes these calculations erroneously on the right ventricle. Another type of situation would be a patient with a prosthetic mitral valve, in which this reflection of this acoustic reflection will actually not allow the program to identify the left atrium. And the other type of situation would be these patients that have a hyperdynamic left ventricle. You can see nicely here that the borders are not truly following it. We have had the opportunity to compare the heart model with and without manual corrections against cardiac MRI in approximately 100 patients. And you can see that the correlation with low, small biases and low limits of agreement. With respect to the left atrium compared to cardiac MRI, we get slightly a larger underestimation that can get immediately corrected with editing. One of the biggest, I think, improvements of this model is the excellent reproducibility. If I take, for example, a 3D manual measurements, and I do I trace it, and then I go and trace it again myself. A couple of days later, or a colleague of mine will trace it. You can see that the intra and inter-observed variability is anywhere around 10 to 15%. When you do the same calculations with a heart model, you can see that the variability is cut in half. So despite the fact that you can do manual or no manual corrections, the variability with this heart model is smaller than when you do regular echo. And that is, I think, one of the huge advantages, is that you can do this relatively accurately, and you can do this with a very small variability. And the other, I think, huge advantage is if you think about the time it takes. I told you that if we take 50 echoes and we do the calculations of volumes for the left and ventricle and atrium, it would take me about 5 hours. If I use the heart model with minor edits, I can decrease 63% to about an hour and 60 minutes. And if I use the heart model without any corrections, all of this will take me approximately 33 minutes. So there is a huge gain savings. And I think it's probably fair to say that you would use this one, the 3D heart model with minor edits. So you are decreasing the amount of time it takes you to get these volumes in about 63%. So I think that this model, I hope that many of you get the opportunity to test it, has very good inter and intra-observed variability and also very good retest variability. So in my opinion, I think that the automated simultaneous, meaning you can do both of them at the same time, quantification of left atrium and left ventricular volumes is possible. And hoping that if we all meet soon, we will be able to do also the right ventricular and the right atrium, all from a single beat or with 2 different acquisitions. These measurements are comparable to CMR, and they're also comparable to when you draw with your hand a 3D echo. This technique I would like to bring to you is reproducible and time savings. And this, I hope that this automated algorithm will allow 3D echo to be part of the routine clinical lab. Thank you very much.
So good afternoon, everybody, and welcome to Thailand. I think the part of that I'm going to talk later after Professor Lang is about the experience with the heart model from the beginning. Since I work in King Chulalongkorn Memorial Hospital, which is one of the test sites, and I believe is the one that sent the image to that 1,000 images in the library for the heart model. So I think that this is my experience with the heart model. And I have to tell you that this is the experience with the work in progress heart model. So it's the testing. And the final one may be different from this, from the feedback and from the process of learning. And I think that it's important thing that we sharing the feedbacks and experience from the user during the test. And it has been a learning process for both of us, I mean that myself and heart model. So it's kind of fun to begin with. When we are all echocardiologists, and when there are requests for echocardiography, I believe that one of the indications is for chamber quantification, especially on the left-sided. the left ventricle and the left atrium. I think we do that on everyday basis. And I think that right ventricle and right atrium may coming in later, but today we are focused on the left-sided. And as Professor Lang has talked before, that right now the left ventricular and left atrial quantification will be based solely, mainly on the 2D echo, the 2D biplane Simpson method. But it also stated that in laboratory with experience in 3D measurement in reporting is recommended when feasible, depending on image quality. And I think that's important part. So when our Echo Lab agreed to be the test and submit the image for testing of the heart model, the requirement is that you have the EPIC 7C and the X51 transducer, the 3D capability. And after installing the software, at that time we had the EPIC version 1.3. You will get the two buttons on the screen. The one is the acquisition. It's called the heart model acquisition. And the other one is during the analysis. You'll get the button on the screen called HM or heart model. And that's the only difference between the one that had heart model and the one that hadn't heart model on that. The data that we get for each subjects or each data set is the date that we do the study, identifier, height, weight, body surface area, gender, and heart size, and that separate into 3 categories. And we have to do another measurement of the ejection fraction, whether it would be the 2D personal long axis, M-mode biplane or visual estimation, or 3D, in addition to heart model ejection fraction. And we report the heart model ejection fraction and stated whether the border for the heart model was edited or not, or it traced the border correctly from the beginning and the sonographer initial. Since I don't have many sonographers in my lab, so almost all of the images or the data acquisition is done by myself. We begin the first subjects acquisition for the heart model on September the 1st, 2014, and we have completed 75 subjects. And the patient gave verbal consent, no patient identification attached to the data set that was completed and uploaded by the web to the lab. And what I would like to state is that we have a varieties of the patient body build. We have the body surface area is small as 1.23, and that the one that was rather the heavily built, that's it 2. And the female and male ratio is 2.1. And the mean ejection fraction for the 75 is 56. So most is normal ejection fraction. But we have some patient who has severely impaired LV systolic function from ejection fraction as low as 18 to the one that is hyperdynamic as 84. And the LV diastolic volume, we had mostly it's normal or rather small, but we also have the one that has large LV diastolic volume. And the way that you acquire the data set for the heart model, you begin with the apical 4-chamber and optimize the 2D image and make sure that all of the LV and LA on the left-sided structures is in the data set. This data set, I would like to point out that although you see on the 4-chamber that all of the LV and LA is in the sector, but when you have the cross plane, you see that the apex of the LV is out. So if you get this data set, it would not be able to do the heart model or analysis of the 3D volume. And if you are satisfied with the biplane that you get both the left ventricle and the left atrium in the data set, you can press the heart model acquisition, and that would bring up the preset at that time, it was 3D full volume and the 4-beat acquisition at that time. And then you acquire the image. And when you get the image and bring it to review, it will have the button on the touch screen that say HeartModel, and then you press it. And what you see is that what Professor Lang showed you, that it would take less than 20 seconds to get the result of the analysis. And it will come up like this. So you have the 3-plane of the 3D data set, the 4-chamber, the 2-chamber, and the apical long axis. And then you get the model, the HeartModel here. And you get the LV volume, the systolic volume, LA, and you get the calculation of ejection fraction and stroke volume here. So it sounds easy and it's nice. And what I love about it is that the report from the HeartModel is already transferred into the report and Accelera already. What I would like to put an additional note on that is that during the work of testing, what I note and I feedback to Philips or the HeartModel team, the first one is that when we're testing HeartModel, it will analyze the data that was acquired in the left ventricle on the right-hand side, or ASE orientation. Since I was usually acquire the image on the left ventricle on the left side, that was pretty difficult for me at first. But right now, after I asked Philips and get some requests, the released HeartModel right now in the final model can analyze the data acquired either way, whether you have it the left ventricle on the left side or the left ventricle on the right side. So that's nice. And my note during image acquisition and testing the HeartModel is you have to try to get the whole LV and LA into 3D data set. That I was point out that maybe looking at one plane is not enough. Even if you have the 3D data set, you have to go through cross-section of the LVs to make sure that there's no part of the left ventricle that dropped out. And the note number 3 at that time is that HeartModel acquisition was acquired in the 3D full volume 4-beat acquisition. So that time we can have stitch artifact because it will stitch together the 4-beat acquisition. And you cannot do HeartModel on the people who has irregular rhythm, especially the atrial fibrillation. And that's the one that we need to have the quantification. That's the one that need quantification. So, I mean, that's my kind of the feedback that I would like to have the 1-beat high volume rate. Is it possible, something like that? And I don't know, maybe it's not because of my feedback, of course, but the released HeartModel right now is working on 1-beat high volume rate acquisition. So that's nice, so that we can extend the acquisition and using of this technique for the larger range of patients. And about the, at that time, the HeartModel may haven't learned enough. But I think that after about 10,000 data set in the libraries, I think right now the algorithm for tracing has been improving so much that I don't think that you will have that kind of the tracing outside that the sector like this one anymore. So it's right now is more reliable and more robust, and it should work across the different region of the world because there are input from many different countries also. And the HeartModel is right now, when I had the HeartModel in the EPIC, I think it's very, very nice complement on the 3D quantification position. We have the 3DQ and 3DQA in the past, and right now we have HeartModel, and it's nice to have the auto detection of the left ventricular volume, left ventricular ejection fraction, you get LV volume, But I must point out that the HeartModel is complementary, and you still have the place to use the 3DQ and 3DQA. So I'm very happy that right now the HeartModel that we have already tested with collaborating with Philips has right now is ready for release. It's like you're seeing your child is beginning to take first step into the world. And in summary, I think that the 3D echo has improved in image acquisition, image quality, but the gap is how to incorporate into every workflow. And I think the HeartModel will have a strong impact on how we quantify 3D echo, and it has taken into account the different chamber geometry across geographic region. I would like to thank you, all the patient subjects, the staffs in my echo lab, for bearing with me during the image acquisition, the HeartModel team and the Philips. Thank you for listening to the feedback and improving something that is very important for the field of echocardiography. And thank you all for your kind attention. Thank you.
I think we would be very happy to answer any questions that there are regarding the HeartModel. Yeah, I think there is a... Yes, thank you.
Javed Akhtar from Canada. You know, I can see how the HeartModel could work well in good image quality patients, but in North America, for instance, where at least I think 50% of the patients that show up to my lab are 200 pounds or more, how does it work in that population for edge detection so that it can do its algorithm?
Yeah, so the first thing that I would, that's a good question. The first thing that I would answer would be that the HeartModel has not been tested to work with contrast, so it doesn't. On the other hand, the good thing is that, I mean, in Chicago, I'm sure that we have the same sort of patient populations that you get in Canada. We can make this work in about 80% of the patients when you do this, you know, without separating any type of patients. I think the proof will be eventually, this is something that is very new, but eventually the proof would be to do a study in which in a lab you would and allow all your machines, and you would do it in every patient and compare it to what you would do with a hand-drawn echo, or you would have to, and then determine exactly how many patients you would eliminate because of quality. But it is pretty encouraging. It works pretty good in not every patient, but in about 80% of patients.
Thank you.
Thank you. Any other question? Yeah.
Professor Lang, you show the image of the patient who has the prosthetic mitral valve, and that will impact on the LV volume only, right? We can still quantify the left ventricle. Is that correct?
Yeah, the acoustic shadowing of the metallic prosthetic valve does not allow you to do the calculation of the left atrium. You could still make it work for the left ventricle.
I am Desho Chakrapanisku from Sriraj Hospital. Thank you, Dr. Lang, for your introduction and talk about the 3D in quantification like this. It's really happy. I'm really happy that the work that I do for a long, long time, up to now, maybe 20 years, have anyone who do the best than previously. Previously, when I do the quantification of the LV cast, 20 years ago, I have to draw it by hand, and we use what we call the neural network to detect the blood-border interface so that we can detect which is the border of the LV. It seems this algorithm was used partially or in this, I don't know, but it's good so that we can less interact with the data set. And to have the value to be accurate is important because the 3D stuff, what important is about the information that we got. It's not the shape, the image only. So the importance of the data is the accuracy of the data. The only thing is to have this software to work in the machine. If we use the algorithm of the neural network combined with the thresholding, the power of the machine need to be quite high. But today, technology can allow. 20 years ago, we cannot. But now it's maybe. So it's the first big step in another way that in the future, maybe we can have the patient lie down, take the image, 1, 2, 3, 4, okay, that's all. I think this may become true in the near future. Thank you.
Well, we'll see about that. But that is definitely, this is a good beginning. And if you think about it, you now need to create a model of the RV with a lot of pressure, volume overload, TR, etc., in order to be able to do it. And I think that a lot of things in Echo will go this way of creating these models for then a computer to try and identify the particular geometry. And well, we'll see if we can do an Echo very, very quickly. See if we get paid for that.
Prof, I'm Lam from Malaysia. I was just wondering whether your heart model has been looked into those atrial fibrillation, grossly abnormal LV dilatation, aneurysm. Has there been any collaboration or into looking into CMR? Has there been any sort of a validation, how close they are?
So that is a very good, excellent question. So the patients that have been studied up to now were not in atrial fibrillation, because despite the fact that what she nicely explained, that you now acquire just one beat, and now you can get frame rates in over 20 frames per second. This has not been studied in patients with atrial fibrillation. If you think about patients with aneurysms that have a large dyskinetic segment, this could work, but these type of patients have not been incorporated into the model yet. So whether that will work or not is something that we'll need to say. Excellent question. Now this does not work because these hearts, those shapes of heart, when I showed you the different shapes, there is not a shape with a ventricle that has either an inferior aneurysm or an apical aneurysm. So these have not been still studied.
Left bundle branch block? Patient with left bundle branch block?
That's also a very good question. These patients have not been studied yet. And it will be somehow, you have to have a really good frame rate to be able to follow. So these patients have not been studied yet.
So I want to just thank you all for coming and attending this lecture, specifically thanking Dr. Simonpour and Dr. Lang for their very good comments. And if you do want to see more about the heart model, I'm sure anybody from the Philips team would be delighted to talk to you about it. So thank you and enjoy the rest of the meeting.
So the meeting will, now it is 1 o'clock. We have finished exactly on time. So the meeting will resume at 1:20 with valve diseases, and we'll start talking about the aortic valve at 1:20. And again, when you compare these models with, you compare the model with CMR or with manual tracings,